afternoon, everyone, and welcome to our webinar where we're going to be outlining the new regulatory model at the CQC. Really delighted to be here with everyone. My name's Rosie Benneyworth. I'm the Chief Inspector of Primary Medical Services and Integrated Care, and we've got about an hour to go through our approach and then answer lots of questions. So I'd just like to make some introductions first. If we could go on to the next slide. So there's a team of us here who will be with you for the next hour. I'm joined by Andy Brand, who's the Interim Head of Inspection in the East of England and leads much of our GP work. Dr Tim Ballard, a National Professional Advisor who many of you will know in general practice. John Milne, who's our National Professional Advisor in Oral Health and Dentistry. David Gwyther, who is our Communications and Engagement Manager. Latoya, who's our Provider Engagement Officer, and Steph, who's our Events Organiser. So thank you to everyone who's joined me this afternoon. We want this to be a really useful and productive time. Any problems with the technology, if you can't hear anyone or any problems, just stick it in the chat and we'll address it. We want to stick to time, absolutely. The way this is set up, only the people in the webinar can speak, but we want to capture all your thoughts and questions. So please put thoughts, questions, comments in the chat, and we will be looking at those and picking out the questions to answer at the end, but really want to capture all your comments and thoughts as we go through. Just so you're aware, we are recording this webinar and we will be uploading it onto a YouTube channel, and we can share the slides with you after this event, so you'll have the information. So if we could go to the next slide, please, Steph. So what we're going to cover today, I'm briefly going to recap on the CQC strategy that we published last year. We're then going to talk about the CQC Primary Medical and Dental Services regulatory approach and our inspection priorities. We're going to talk about our current and future model, our assessment framework, and then go into questions. So if we could go on to the next slide, and I hope you can see this. I know the writing is very little, but I just want to recap on our strategy. We've talked a lot about our strategy over the last year, and it's important to acknowledge we're still in year one of a 5-year strategy, and we're continuing to take feedback on our progress, including in our local authority and systems discussions. So we're changing very much how we regulate to improve the care for people using services right across all sectors. We want to be more relevant to the way care is delivered, more flexible to manage risk and uncertainty. We want to be able to respond quicker, more proportionately, and we want to be able to keep ratings up to date. Our purpose and our role across the system isn't changing, but we know that how we achieve that needs to change to meet the changes that we're seeing across the health and care sector. Our strategy set an ambition to deliver an approach to regulation that's been driven by needs and experience of people and community, focusing on safer cultures, learning and collaboration across health and care, and a focus that accelerates improvement. We need to see as a regulator how we can ensure improvement occurs. We know that we need to be smarter as a regulator, and we need to make better use of data and insight. And this is part of our what we're doing at the moment, as we'll talk about. We know that the health and care environment continues to change rapidly, and we need to evolve to meet that. So in year one, working in partnership with others, our focus is on firstly developing how we monitor risk and test a new assessment framework, and this will look both at provider level assessments, but also what's happening across a local area. We want to develop a stronger understanding of what impacts the quality of care, communicating across health and social care sectors and with the public using our independent voice through reports such as State of Care. This will be supported by the development of a new provider portal and a mobile-friendly website, so providers, strategic partners and the public can access our information more easily. We know that it's not always been easy in the past. We want to carry out further research and engagement to deliver our collaborative work on safety and improvement. This will involve and include looking at how we can use our convening power to bring about improvement coalitions. We won't be an improvement body ourselves, but we need to make sure that if organisations need support with improvement, that they get that support. We want to work with partners to really agree a definition around safety across sectors, and we'll be clear how we regulate safety cultures and empower services to improve. And we'll be exploring our approach to assess how local systems understand the needs of their local populations, especially people who face the most barriers to accessing good care, those with the poorest outcomes. And we're all concerned at the moment how what's happening with inequalities and what's happened during the pandemic. And we want to enable systems to proactively address these inequalities. So that's something that's also a key focus for us. So I now want to hand over to Andy, who's going to talk through our current regulatory approach. So Andy, over to you.
Thanks, Rosie. So throughout the pandemic, we've kept our regulatory approach under review, and that's been in recognition of the changing pressures that health and social care services find themselves working under. Our priority has always been to support services to ensure that people receive safe care, and we want to ensure that our approach is both appropriate and proportionate. Considering the current situation, and that includes the easing of restrictions across the country, we've reviewed and updated our regulatory approach. And in January, we shared a statement on our regulatory approach from the 1st of February 2022. And since then, we've been inspecting where there's evidence that people are at risk of harm, and that applies to all health and social care services, including those where inspections were previously postponed due to the pandemic, and that was except in cases where we had evidence of risk to life. We've been inspecting where we can support increasing capacity across the system, particularly in adult social care, and we've been inspecting where a focus on the urgent and emergency care system will help us understand the pressures where local national support is needed and share good practice to drive improvement. If we could move on to the next slide, please. So, as well as the follow-up inspections of services rated inadequate and those in special measures, and the inspections of urgent and emergency care services, and I'll say a bit more about that on the next slide, we're going to be undertaking a small sample of inspections of services that we've issued public statements to. And by that, I mean services currently rated good or outstanding, where we've carried out an automated review of the information we have available to us and decided that as a result, we don't need to reassess our rating or carry out an inspection at the moment. And we put a statement on to that effect on the provider's profile page on our CQC website. And by doing that, we aim to seek assurance about our intelligence model to confirm that they do actually remain good or outstanding and that we were right to publish that public statement in the first place. We're also undertaking a small sample of inspections of locations which have had a monitoring call from us and where the decision was that no further action was required. And again, that's to seek assurance about that decision and our intelligence model. So if we could move on to the next slide, please. Since the 1st of February, we've restarted work to coordinate our approach to inspecting urgent and emergency care pathways. Where we identify risk, we'll look at how services across the system are working together. This will help us understand where the pressures are and any needs for local or national support. We'll share the good practice we see to help drive change and improvement that could benefit people using services and staff delivering care. As we know, urgent and emergency care services, UEC services, across England have been and continue to be under sustained pressure. And in response, we're undertaking a series of coordinated inspections, monitoring calls and data analysis within local areas. And that helps us to understand how local services work together to ensure patients receive safe, effective and timely care. So this is part of a pilot that tests a coordinated multidisciplinary approach to assessing services across an integrated care system, otherwise known as an ICS. And as you probably know, an ICS consists of all healthcare partners in a specific geographical area, including, but not limited to, care homes, GP practices, NHS 111 providers, community services, mental health trusts, and NHS trusts, including ambulance services. And these inspections help us to see how services respond to the challenges they face as individual providers, but that require a system-wide response. The inspections also help to support ICSs to better understand the journey people experience when seeking urgent care, and this in turn helps identify where they can make improvements. Out of these inspections, each provider receives their own report with our findings, which includes a system summary, but we don't publish separate reports for each ICS as a whole. And by way of a link into the next slide, which takes us into dentistry, I should also mention the role of dental care in the performance of urgent emergency care services, where we're finding significant numbers of dental calls coming through to 111 services, for example, and patients needing dental treatment turning up in A&E because they've not been able to access emergency dental care in their area. And with that, I'll hand over to John.
Thank you. And picking up that issue of dental services, of course, the issue of oral health is an important one in terms of integrated care systems as well. But we're going to have some priorities for looking at dental practices going forward, and I'm going to speak about those. And I'm also going to touch on some of the more generic work that follows from our assessment framework. So in terms of dental practices and the like, there are some practices that haven't been looked at since 2015 or before. In fact, there's 3,500 of them, and there is some evidence of increased risk in the practices that we haven't had much contact with so far. So that will be one of our priorities. Quite a lot of dental practices, thick end of 20% of dental practices provide services using conscious sedation, and where there's poor sedation practice, that can put the members of the public at serious risk. So we will continue to monitor that with practices. We've already streamlined our inspection process during the last year, and that work's ongoing with practices that we look at the moment, but we'll further develop smarter working in line with the proposed assessment frameworks as we move forward. We're going to improve our data collection processes, and we'll work in co-production with dental stakeholders. That's a really important part of the developing of this future work, is that rather than impose stuff on providers, we want to work with dental providers to get the assessment right and the evidence right. We see the use of the DMA, it's in-house. It's an essential component of our smarter model because it maintains portfolio relationships and expands our touch. It expands the number of practices that we actually have contact with. It assists in the management of risk, and it'll provide an important skill mix opportunity for managers in what's an under-resourced function at the moment. And the dental sector, as many of you will know, is information light. So collecting information for us is a priority, and working on ways of getting the information that we receive so it actually encapsulates all the issues that are around dental practice is very important. We're going to be focusing on the safe, effective and well-led areas in the immediate future. Also, some of you will remember we did some work about access to dentistry at the back end of last year, and this access to NHS dentistry is a particular issue in some parts of the country. These are system-wide issues, and we'll monitor that with partners such as Healthwatch, and we'll also examine to what extent providers themselves are able to help address the access issue. Smiling Matters was a project about oral health in care homes, and we're going to monitor to what extent there have been improvements in that area where we raised questions for providers, commissioners and for our own systems in regulating ASC. And in addition to that, we've been working with the oral health team about looking at the aspects of oral health that are covered with the acute sector, and we'll be continuing with that work. And so if we can change the slide, please, I'm going to move on to a more generic part of the process. We know it's helpful, I think, to see how our future model relates to what we've been doing over the last 8 years or more. And here are some examples coming up of what could feel different. So our assessment framework at the moment has got 4 different frameworks. 2 at registration, and then in healthcare and adult social care, each covering our 5 key questions, and we believe that they're duplicative, particularly across the key lines of inquiry, and they're not fully relevant to health and care today. So in the future, we're going to have a single assessment framework that we'll use to assess quality in all types of service and at all levels, from registration through to ongoing assessments of quality, as well as with local authorities and integrated care systems. And this will simplify things greater for providers and for ourselves. Much of this assessment framework will be familiar to you. We're not reinventing the wheel in what we look at. Good care will still be good care, and poor care less so. But what will look and feel different is how we're going to apply the process, and the process will follow to make those assessments of quality. So at the moment, we have a separate monitor, inspect and rate steps, and we inspect at a set point in time that's often based on the previous rating. In the future, we're going to move away from that separate monitor, inspect and rate steps in our model, and instead we'll use the information that we receive, collect and analyse to assess providers more frequently without necessarily being tied to set dates. We do recognise that visiting providers on site is still an important part of our process. And now, in terms of categorising and scoring evidence, we make judgments against the ratings characteristics, and the key question ratings aggregate to give us an overall rating. In the future, we want to be more consistent and more transparent in our approach and how we make judgments about quality. So we want our ratings, where we use them, to better reflect the care that people are receiving, and to be clearer about where a provider or a service sits within a rating. And so to address that, we're going to develop a way to categorise and score evidence as part of our assessments. In terms of reporting and outputs from our assessments, what we do now is we publish long PDF reports that are not very accessible and take time for us to write and take time for the public to read. So in the future, we're going to move away from the long PDF reports. We know they don't work for the public. We don't think they work necessarily well for providers too. They're inaccessible and not fit for what people expect from us. So we also know they take up much of our inspectors' valuable time to produce them in the first place. So we'll be able to give a much more up-to-date view of quality. We can't do that unless we streamline the processes around publishing reports. We want to make them shorter and more tailored to the audiences that use and read them. People will be able to make better choices about their care, as the information will be presented more clearly, and there'll be detailed benchmarking information to help providers improve. And they'll also be able to use the provider portal rather than necessarily be published online. And so if we can move to the next slide, we'll just look at the assessment framework in a bit more detail. So our assessment framework continues to be built on our 5 key questions, and our well-known rating system, which is used in many areas of health and social care that we regulate, is what we use to set out our view of quality and to make judgments. We've drawn on work done previously by Think Local, Act Personal, or TLAP as it's called, National Voices and the Coalition for Collaborative Care on Making It Real. And they've co-produced a personalised care and a support framework that can be used by people who work in adult social care. It can also be used in health, housing, and with people who use services. And importantly, this sets out what good and outstanding person-centred care looks like, and what people should expect from providers, from commissioners, and from system leaders. We're going to use what are called I statements as the starting point of our assessment framework. It takes the important first step towards truly regulating through the eyes of the public. As the statements encapsulate the views and expectations of real people, we feel that giving them a prominent voice in our single assessment framework helps to focus the whole health and social care system on people at a very human and relatable level. We've already confirmed that our ratings and 5 key questions will stay central to our approach. But what we're going to do is introduce a set of quality statements pitched at the level of good and linked to the regulations that will help us make our judgments about the quality of care. They'll replace our current key lines of inquiry and prompts, and they'll be expressed as we statements, helping to make things clearer for providers about our expectations on them, whilst reducing some of the duplication that currently exists across our key lines of inquiry, or CLOEs. We'll use this set of statements in our assessment for all sectors and all service types and at all levels, using them to register services with a provisional rating of good, through to our new work looking at local authorities and integrated care systems, and this will be the basis for our single assessment framework. We want to be more consistent and transparent in our approach and how we make judgments on quality. And so to address this, we're developing a way to categorise and score evidence as part of our assessments. And the evidence categories will bring more structure to our process for assessing quality. There'll be 6 categories of evidence, and those will be people's experiences, feedback from staff and leaders, from observations of care, feedback from partners that providers work with, the processes that providers operate with, and lastly, the outcomes of the care that people give. And so to enable us to be clearer with providers and the public about how we use the information we have about care in a service or a local area, we'll set out what evidence will be required for each service type and at each level, including at registration. And in many ways, this will all be data and evidence already familiar to providers and to our inspectors. But by bringing in the 6 categories and setting what we always need to collect and review in order to make a decision, alongside a way of scoring evidence, we're able to bring a more structured and consistent framework for assessing quality across all the services that we regulate. And our single assessment framework will act as a golden thread from initially registering a service at the level of good through to ongoing assessments of quality. And I'm going to hand over to Tim now, who's our GP National Advisor, and he's going to expand on this a little bit more.
Thanks, John. We've already confirmed that our ratings and the 5 key questions will stay central to our approach, but as the reference point for our assessment framework, we want to use I statements, as John said, to set out the views and expectations of real people. We hope that in giving them a prominent place, they will help to focus the whole health and social care system on people and at a very human and relatable level. We're also introducing a set of quality statements pitched at the level of good and linked to the regulations to help us to make judgments about quality. And they will replace our current key lines of inquiries and prompts and be expressed as we statements, helping to make things clearer for providers about our expectations on them, while reducing the duplication that currently exists across our CLOEs. To make some of this more tangible, here on this slide are 2 examples drawn from our new assessment framework, an I statement and a we statement, covering the topic of a safe system, pathways and transitions relating to people's care. Next slide, please. This slide just illustrates our approach using the I statements, the key questions, and the we statements, the quality statements. You'll be pleased to know that I'm not going to read them all out to you now, but I'll just give you a short time to look at the different categories. Thanks. Can we just move on to the next slide, please? The required evidence will be tailored to each service type to ensure that a meaningful assessment is made, and at service type level, we'll change the lower evidence requirement that more frequently than the quality statements, in line with the most up-to-date practice standards, authoritative guidance, and academic research, and where we have evidence that we may wish to move the quality bar. The evidence required to make an assessment against each topic area and related quality statements will be specified and made clear. This will be structured and based on 6 evidence types. They signal the types of evidence we use to understand the quality of care being delivered against each quality statement. And these are based on what our existing CLOEs seek to uncover. We'll want to look at what are people's experience? What do staff and leaders tell us? What have we heard from our partners? What have we observed? What do we know from the organisation's process, their systems, policies and records? And what can we learn from outcomes and performance data? Now, the required evidence will differ according to registration, what regulated activities is a provider registered for, an ongoing quality assessment. It will depend upon the service model and also the level of assessment. For example, whether we're looking at an individual service provider like a general practice or a dental surgery, or an integrated care system. Our system will link best practice standards and authoritative guidance to the topic areas and related quality statements in our digitally hosted assessment tool for all sectors. Now I'm going to hand you back to Rosie.
Thank you very much, Tim. So I'm just going to spend a couple of minutes talking about systems, integrated care systems, and the work that we're doing in this area. So the new health and care bill that's going through at the moment, there's an amendment in that gives us 2 new powers at the CQC. One is for us to be able to assess integrated care systems, and the other is going to give us the powers to look at local authority assessments in meeting the Care Act. This is a really important step for us. I think up to now we've only been able to look at quality within a provider. And we all know from our own work and personal experiences that actually people's care often is so dependent on how all the providers in a local area work together to be able to meet their needs. So this is a very important step for us going forward. In terms of integrated care systems, there's likely to be 3 areas that we look at. One is the leadership of ICSs, looking at things like how they understand their population needs and how they are delivering care that meets the population needs, how they're looking at interoperability of IT systems, how they're looking at inequalities, a whole range of things along those lines. How are they working, delegating responsibility to place level, for example. What it's not going to be is an aggregation of all of the ratings of providers in the local area and saying, well, actually 90% of providers are good, therefore the ICS is good, because that doesn't really tell us what added value the ICS is making. So so that will be the focus of leadership. We will be wanting to make sure, though, that the leaders of an ICS are supporting providers to improve, and that there is consistent improvement support offers across an ICS for all sectors. And I think particularly as we're on a PMS call, I will say this as well. I think it's really, really important that I've long felt that all sectors need a strong voice across an integrated care system, and I think we need to make sure that GPs, dentists, all primary care providers, optometrists, pharmacists are getting their voice heard loud and clear at the integrated care system. So we will be looking out for that as well during our ICS work. In terms of integration, there's a whole range of different pathways that we could look at through this. For example, end-of-life care, we could look at the urgent emergency care pathway, and we will be working through what type of pathways we look at. And then quality and safety, we know that there is sometimes big gaps that can emerge and can cause quality and safety issues for patients, such as transfer of medication from different providers, discharge arrangements, referral arrangements from primary to secondary care, for example. So we need to be looking at those and working out how we ensure good quality care as people move across different parts of the health and care system. The local authority areas assessments, they're going to be looking at a range of issues and looking at how local authorities work with their local populations, provide support, look at ensuring safety in areas such as safeguarding, safe systems, continuity of care, and also look at leadership, governance, learning, improvement, innovation, for example. So we will be using the same assessment framework for both of these areas of work that that John and Tim have talked about, and I think what we need to work through over the next few months is how the regulation of providers and the regulation of systems works together. So if we hear themes about a provider in our system regulation, we need to make sure that that information flows, and likewise the other way around. If we're hearing from providers in a local area that there's problems cross system, then we will be picking that up as well. We are co-producing our work in this area, lots of people involved, and we want to get it right with an aim of rolling this out for April 23. So lots of work going on in that area at the moment. So if we could go on to the next slide, please, Steph, that would be fantastic. So finally, just to let you know what's next. So we are continuing to work with lots of people to develop this new model further. We want to test this and we want to make sure that what sounds right in theory actually works in practice. So we will be looking for providers to scenario test this and work through the methodology we've said. We want to be very much the improvement organisation that we ask all of our providers to be, and learn as we go and iterate our approach to make sure that we really add value and that we make sure that people get the best quality care that they can. So we will be wanting to work with lots of you and co-produce this, so please look out for more details about how you can get involved in this going forward. We also will be looking, we are going through some changes in the organisation to set out multidisciplinary teams, and these multidisciplinary teams will work together so they understand risk in an area and work much more flexibly across a local area, so we can share learning and really kind of explore some of those complex issues in more detail whilst maintaining our sector specific knowledge. So my final slide is just to how to stay up to date. We've got lots going on, but we want to make sure that people feel informed and can get involved, and lots of ways of getting involved in the conversation, and particularly we've got our digital platform Citizen Lab where we want to hear your views. We send out regular provider bulletins and blogs. Any feedback about those always very welcome. And we have social media presence as well on Twitter, and we've increasingly been using podcasts as a way of trying to spread some of our messages, so please look out for those as well.